everybody. Dr. Rafich here from Vet Triage. It is Saturday, January 11, 2025, 12:59 p.m. Pacific Time, and we're going through this October 2024 edition of Veterinary Surgery. We're going to be talking about chylothorax again, anastomosis of the caudal thoracic duct, and intercostal vein using a microvascular anastomotic coupler device, an experimental study in 6 dogs. At the bottom, we have a picture of what the anatomy is from the lymphatic drainage from the small intestine through the cisterna chyli and then into the thoracic cavity via the thoracic duct for it to enter the cardiovascular system. And there's a previous video we did a couple days ago that went into more detail as far as what that anatomy goes, so check out that video as well. In fact, it's probably the same folks who did this study coming out of University of Wisconsin-Madison. All right. The objective is to describe a technique for anastomosis of the caudal thoracic duct to the 10th or 11th intercostal vein. They're using a microvascular anastomotic coupler, and it's in dogs to assess patency of the anastomosis on day 0 and day 30. They used 6 adult beagle dogs, experimental study. For the methods, they used a fluoroscopic popliteal lymphangiography. They identified the right 9th or 10th intercostal veins through a thoracotomy, and they used an operating microscope. The microvascular anastomotic coupler was either size 1.5 or 2 millimeter, and then postoperatively, immediately and on day 30, they repeated the fluoroscopic popliteal lymphangiography. They found the anastomosis was successful. It documented flow into the azygous vein in all 6 dogs. At day 30, it was patent in 4 out of 6 dogs. In 2 dogs, it was failed due to obstruction from kinking of the intercostal vein just cranial to the microvascular anastomotic coupler. All right, introduction. Idiopathic chylous effusion in dogs, also known as chylothorax, is likely due to obstruction of normal flow of chyle from the thoracic duct to the cranial vena cava or jugular vein, resulting in leakage of the terminal lymphatics into the cranial mediastinum. Current treatments involve some sort of ligation of the thoracic duct and ablation of the cisterna chyli to eliminate flow and redirect it away from thoracic lymphatics via acquired lymphatico-venous anastomoses created in the area of the cisterna chyli ablation. Success is about 80%. Insufficient formation of lymphatico-venous anastomoses resulting in progressive hypertension within the abdominal lymphatic system. This hypertension leads to development of collateral lymphatics that bypass the site of the thoracic duct ligation, resulting in persistent leakage from lymphatics into the cranial mediastinum. The anastomosis from the caudal thoracic duct to an adjacent intercostal vein has been performed in canine cadavers, and I think that was the last study we did a few days ago. Lymphatico-venous anastomosis has been applied in humans. Causes of chylothorax include truncal lymphatic malformations or iatrogenic damage to the thoracic duct. Thoracic duct or other major lymphatic vessels to veins like the azygous or smaller adjacent veins is part of the therapeutic approach. These anastomoses are executed in either an end-to-end or end-to-side fashion using simple interrupted pattern with hand suture technique. Observed improvements in clinical signs and persistence of patent anastomoses for a duration of at least 2 years after surgery has been reported. Materials and methods. For anesthesia, they use hydromorphone, dexmedetomidine, propofol, isoflurane, oxygen, endotracheal intubation, mechanical ventilation, a right intercostal nerve block from ribs 8 to 11. Liposomal bupivacaine was used for the nerve block. They also gave mirapatent and cefazolin, fentanyl, and the subcutaneous tissue and muscle of the incision was infiltrated with liposomal bupivacaine upon closure. They use a non-ionic iodinated contrast solution known as Omnipaque for the fluoroscopy. And here's some pretty cool images. There we go. So this is intraoperatively. You can see there in the top one we have the azygous vein, AV, and the sympathetic trunk, ST. And then there's the application of the device. There you go. Pretty cool. All right. Post-op analgesia. Oh, here's another picture too. So this is there you go. There you go. Right there. The device is on the structures there, and then you have the imaging, which is not great quality. It's supposed to show the anastomosis. Post-op, they got fentanyl as well as a transdermal fentanyl patch, carprofen, hydromorphone, and they used a Glasgow composite pain scale. The chest tube was aspirated every 6 hours and removed within 18 hours after surgery. The dogs were then tested post-op and 30 days post-op, and then they were euthanized with pentobarbital. On gross examination, the anastomoses were examined using a surgical microscope and removed end block from the dog. Then they assessed patency via infusion of saline and methylene blue via catheter inserted into either the azygous vein or thoracic duct. And so here are the end block removals. There you can see on this side is before they injected saline and methylene blue. On that side, you can see that they're all inflated now with fluid, showing the patency of the anastomosis. For fluoroscopic popliteal lymphangiography, it identified the thoracic duct and its branches in all of the dogs. 3 dogs had 2 branches at the level of the 9th intercostal space. 1 dog had 1 branch at the 10th intercostal space. 2 dogs had 2 branches at the 10th intercostal space. Just shows you the wide variation, even among 6 dogs. Half of them had variations. And then an average of 12 mils of iohexol was used during preoperative lymphangiography, and then 13 mLs on average postoperative. Regarding lymphatico-venous anastomoses, it was an end-to-end anastomosis. 10th intercostal vein was used in 4 dogs, 11th intercostal vein in 2 dogs, 1.5 millimeter coupler in 4 dogs, 2 millimeter coupler in 2 dogs. Median duration for the dissection anastomosis of the vessels was 195 minutes. Median duration for surgery anesthesia was 296 minutes for surgery and 452 minutes for anesthesia. The duration of dissection anastomosis trended downwards towards the study, with the average of the first 3 procedures being 219 minutes, but then going down to 170 minutes for the second 3 procedures. And just shows you how complex this surgery is. But it did get better over time with the learning curve. It was also noted that clearance of iohexol from the cisterna chyli and thoracic duct appeared more rapid after anastomosis. For the 30-day popliteal lymphangiography in 2 dogs, contrast filled the thoracic duct to the level of the anastomosis but then stopped. All previously noted persistent thoracic duct branches were evident at day 30. In 2 dogs, the persistent thoracic duct branches appear subjectively larger, and then in 1 other dog, he had a new second branch of the thoracic duct identified. Gross examination showed pleural lining had reformed over the anastomosis, and the vessels were covered by a thin layer of fibrous tissue. They confirmed patency of the anastomosis in 4 out of the 6 dogs. In the 2 non-patent ones, they found that the device was malaligned relative to the thoracic duct and intercostal vein. The device had kinked and flattened the intercostal vein. No flow was noted through the anastomoses when they infused it with saline. All right, discussion. The averted anastomosis created by the coupling of the 2 rings minimized the risk of endothelial damage and exposure of the lumen to adventitia tissue, which is a distinct advantage compared to hand sutured anastomoses. CT scan evaluation might be more sensitive imaging modality. They also addressed that in the previous paper that we had. It's more sensitive imaging modality for assessing postoperative patency in cases with better resolution to detect the presence of contrast in the azygous vein, despite the dilutional effect. 4 dogs had persistent thoracic duct branches 30 days post-op. Of those, 2 anastomoses were patent, 2 were not. The impact of the persistent branches on the patency of the anastomosis is unknown. It may have led to some effect on lymphatic flow. Additionally, failing to ligate all the branches of the thoracic duct could impact clinical success of procedures due to persistent flow to the craniomediastinal lymphatics. A recent study reported clinical success with thoracic duct ligation despite the presence of persistent or collateral ducts beyond the thoracic duct ligation site, and thus the impact of persistent branches is not entirely known. Colorization of the contrast material used for popliteal lymphangiography with methylene blue was performed in 2 dogs, but at the time of thoracic duct dissection, it was not useful for identifying branches and thus it was not continued. Intraoperative colorization of thoracic duct branches via popliteal or cecocolic lymph node injection with methylene blue or indocyanine green could be considered to aid in identifying small secondary branches of the thoracic duct and minimize risk of persistent flow to the craniomediastinal lymphatics. The malalignment or displacement of the device during the healing process resulted in kinking. Ideally, the intercostal vein would be located more laterally on the azygos vein to minimize the degree of rotation necessary to align the thoracic duct during anastomosis. Also, in placing the device on the intercostal vein, it should be located at least several millimeters away from the insertion on azygos vein to minimize the risk of kinking. Alternatively, utilizing the azygos vein as a recipient vein and forming an end-to-side anastomosis may eliminate some of these concerns by providing a larger and more stable vessel for attaching the thoracic duct. And that's it. That's it for the study. My criticisms are, of course, we want to have more dogs, which they mentioned as well. It'd be good if there was more time to recheck these animals post-op, not just 30 days, but potentially even years, which they also address that. And then finally, it'll be interesting, of course, which will be the next step. Does this procedure work in actual dogs that have the actual disease? Because we all know that the anatomy of those dogs are not going to be normal, and you already saw how much variation there was in the anatomy of the thoracic duct for these dogs. And these dogs are supposed to be normal. So one final thing I'd like to know is whether or not the dogs that had kinking had any clinical signs during the 30 days post-operatively. Did they show any issues or not with that? So, all right, guys, we'll see you again tomorrow. Thanks for supporting the channel and subscribing, and we'll talk to you then. Bye.